Welcome to AETCM, the Emergency Medicine channel. Today let us discuss about management of hypovolemia in emergency room. If we see our body water, you can see here in our body around 40 to 45% is solids and 60% is fluid. In that 2/3 is intracellular fluid, 1/3 is extracellular fluid. In that extracellular fluid, 80% of the fluid is interstitial fluid and 20% of the fluid is plasma fluid. And in emergency room, we mainly target this 20% because any patient who is admitted with hypovolemia, hypotension, shock, all these things, we have to correct the intravascular volume first. If we don't correct the intravascular volume, the circulation will be reduced and that will lead to anaerobic metabolism, lactic acidosis, like that. Now, if we see the compartment in a 70 kg adult man, you can see here total volume may be somewhere around 42 liters, that is 60% of the body weight. In that, intravascular fluid will be around 3 liters. That is very important. This knowledge is very important because when we are managing a case in emergency room for hypovolemia, we may have to give around 3 liters to correct the intravascular volume depletion in a person who is having weight of 70 kg. But you also should know that there will be a reduction in the extravascular volume also, like interstitial fluid, extracellular fluid also we have to correct sometimes. For that, we have to give additional fluid after correcting the intravascular volume. Now, we can see the causes for hypovolemia. Extracellular fluid or reduced extracellular volume, reduced conditions like renal loss and extrarenal loss, vomiting, diarrhea, sweat, burns, heat, hemorrhagic shock. Renal loss mainly diuretics, osmotic diuresis, diabetes insipidus, hypoaldosteronism, some salt wasting nephropathies, diabetic ketoacidosis. All these things are very common. In that, decay is one of the most common conditions we manage in emergency room where there is severe hypovolemia. Other conditions in extrarenal, it is vomiting and diarrhea. Extracellular volume increased. That means total volume is increased, but intravascular volume alone is reduced. That conditions are cardiac failure, liver failure, kidney failure, hypoalbuminemia, nephrotic syndrome, capillary leak syndromes, sepsis. All these things, volume is there in the body volume is not completely reduced, but intravascular volume is reduced. Now you can see here the symptoms of hypovolemia. One is due to volume depletion itself, thirst, fatigue, weakness, muscle cramps, postural hypotension, confusion, coma, oliguria, concentrated urine, all are due to reduced volume in our body. Second thing, it is related to the cause of the illness, whether it is diarrhea, vomiting, or burns, infections, like that symptoms also will be there. Third one will be electrolyte imbalance. In that, most important electrolyte will be potassium. So potassium is required for muscle activity. Muscle weakness is the classical feature of any type of hypokalemia, and you can see alkalosis also, metabolic alkalosis also in ABG. But many patients who is having severe dehydrations can also develop metabolic acidosis, that is due to lactic acidosis. Now, inadequate perfusion can lead to so many complications. It can reduce the perfusion to internal circulation, anaerobic metabolism, and lactic acidosis. So many abnormalities can occur due to inadequate perfusion. So inadequate perfusion ultimately lead to clinical findings like hypotension, tachycardia, cold clammy skin, tachypnea, drowsiness, confusion, irritability, reduced urine output. JVP will be either reduced or elevated. That depends on the fluid status. Patients who is having cardiac failure, JVP will be elevated but circulation will not occur. Multi-organ dysfunction, poor altered cerebral perfusion lead to low GCS. Now there is an index called as shock index. You can see the mortality rate by this shock index in severe types of shock. It is defined as the heart rate divided by systolic blood pressure. It has been suggested as such a marker that can be used to predict the severity of hypovolemic shock. So shock index, no shock less than 0.6, mild shock 0.6 to 1, moderate shock 1 to 1.4, severe shock more than 1.4. The mortality in severe shock is 39.8% or 40% mortality is there. Now, one important clinical finding which can be done in emergency room to find out whether the patient's perfusion is good or not, that is capillary refill time. This is a very simple test. You can just press the finger tip like this and release it. Normally capillary refill time, that means the white part will become red in less than 2 seconds, but in a patient who is having delayed circulation, that capillary refill time is delayed and the whiteness will remain. The white finger, you can see, that will remain as such for some more time. So capillary refill time less than 2 seconds indicates there is a good perfusion of the peripheries. If it is delayed, then that indicates a bad perfusion. Passive leg raising test is another important investigation, can be done in emergency room to see whether the patient is having volume responsiveness or not. We always check the BP, postural BP, tachycardia, all these things in patient who is having severe dehydration. You can see postural BP will be initially itself it will be dropping. There will be significant reduction in the standing BP if the patient is having dehydrated. But capillary refill time, passive leg raising test is a test which will tell you that whether the patient will improve with fluid or not. For that, you have to keep the patient in semi-recumbent position and suddenly passively raise the legs to 45-degree angle. The effects occur in 30 to 90 seconds. You can see the fluid from the lower leg, lower limbs, it will drain to the central circulation when you are lifting the lower limb. If the patient shows a significant improvement in the systolic BP, then that is a good indicator for fluid responsiveness. If you have a central line or if you have a arterial BP, all these things will add to your clinical judgment. Arterial BP will be one of the simplest thing which can tell you that BP is improving or not. But even otherwise, you can check patient's BP on passively raising the leg. You can check the BP. If there is a significant improvement in systolic BP, then that indicates patient can receive more fluid. So the procedure will be like this. Patient will be lying down like this. Suddenly raise the leg so that the fluid from the limbs, lower limbs, will drain to the central circulation. BP can be slightly increased. If the BP increases, then that shows patient can take more fluid. Patient may not develop any adverse effects due to fluid. So fluid challenge can be given without any fear in this type of patients. So passive leg raising test is a very simple and effective method to find out whether the patient will be fluid responsive or not. Now IVC diameter, little more expertise is required in this area. You need to have a ultrasound machine. You have to know how to do ultrasound for inferior vena cava, and there we are seeing two important things. One is the diameter of IVC, second one is collapsibility more than 50%. In simple words, IVC on USG's collapsed patient can be treated with fluids. IVC collapsibility is there means you can give more fluids. If the IVC is distended, even when there is hypotension, that means patient is having volume overload. The hypotension is due to something else. So a collapsible IVC, that indicates patient can receive more fluid. So you can see here IVC is collapsible. Second ultrasound shows IVC is distended, and if the collapsibility is not there in inspiration expiration change, if the collapsibility is not there, then that indicates patient is volume overloaded. If the collapsibility is more than 50%, that indicates patient can receive some more fluid. Now another important investigation or parameter is central venous pressure, CVP. For that you need to put a central line, and the normal value of central line CVP will be 8 to 10 centimeter of water. If it is low, you can give more water. If it is high, then water should be restricted in this type of patients. So hypotension with low CVP, you can give fluids. Hypotension with high CVP, don't try to give fluids. The problem for hypotension, the cause for hypotension may be something else like cardiac failure or something else. In ventilator patients, that may slightly alter. I am not going to the details of that. But in a patient who is having low CVP, not on ventilator, you can safely give fluids and improve the CVP to 8 to 10 or more than 10 initially itself. So this is CVP monitoring. Now whenever you have a patient who is having hypovolemia, we suspect hypovolemia, you have some lab investigation which can tell you that patient is dehydrated. That one is most important is hemoglobin percentage. Whenever there is severe dehydration, water loss, you can see hemoglobin percentage increases. That's a relative increase in the hemoglobin percentage because of the dehydration. That will be corrected once you give fluid. Then blood urea nitrogen will be elevated, creatinine also will be elevated, but urea will be disproportionately elevated from than creatinine. Suppose in a patient who is having normal creatinine urea ratio may be 1:20. Here it will be more than that. For example, patient who is having severe diarrhea admitted with urea 90, creatinine is only 1. That means there is a disproportionate elevation of the urea. That indicates a pre-renal cause for kidney disease. So pre-renal kidney disease are due to hypovolemia or severe dehydration. Now serum sodium, most of the condition where there is hypovolemia alone, you can see sodium will be high. Hypernatremia is a important finding you can see in volume depletion. Now other investigations, like you have to see lactate, because patient who is having severe dehydration, hypoperfusion, anaerobic metabolism, lactate can be produced and lactic acidosis can be seen in ABG values. Other investigations, you have to see the electrolytes, blood sugars, infection screens, because all these things can contribute to hypovolemia. Like patient who is having severe sepsis, the dehydration may be due to vascular leak. Dengue shock syndrome, dehydration may be due to vascular leak. Hypoalbuminemia, the volume depletion may be due to intravascular collapse due to hypoalbuminemia. So you have to do some more investigation to find out what is the reason for the hypovolemia or hypotension. Now if a patient who is having dehydration alone, like a patient who is having diarrhea, vomiting or volume loss, heat stroke, all these things we have to give fluid replacement. Normally if the patient is not sick, we have to give fluids in a physiological way. We have to ask the patient to take plenty of water through oral route itself. If the patient is having diarrhea, vomiting and all, we have to give ORS, oral rehydration salt. That has to be given. If you see the WHO ORS, this one packet, you can see here, it contains sodium chloride, glucose, potassium chloride, trisodium citrate, dehydrate. All these things are there in the ORS pack. So that has to be dissolved. One pack has to be dissolved in 1 liter of clean drinking water, and it should be prepared for 24 hours. It should discard after 24 hours. So it is only a freshly prepared solution should be used. You should not use this for a longer period. So prepare it in 1 liter water or whatever is advised in the packet, and that should be diluted and given to the patient. Some patients may vomit after taking this ORS. They may not like the taste or smell of the ORS. So in that type of patients, don't try this. You can give water with salt and sugar solution to them, or any other mild solutions like oral drinks also can be given in a patient who is having severe dehydration. Whatever it is, oral replacement of fluid is better than IV replacement in a patient who is having normal clinical features. Now, if the patient is having severe dehydration, patient is not able to take water through oral route or vomiting after taking oral fluids, you have to give IV fluids. That best IV fluid will be normal saline. If the patient is having severe dehydration alone, normal saline will be a better choice than any other fluid. But if the patient is having severe diarrhea, vomiting, electrolyte imbalance is there, then ringer lactate is better than normal saline in most of these type of conditions, because that is most physiological solution available at present. There is one more solution, that is plasmalite. That is a bit costly comparing with ringer lactate. Ringer lactate is available everywhere and it is less costly comparing with plasmalite. So ringer lactate will be a better choice in patient who is having water with electrolyte loss. But whereas in only water loss, if the patient is having diabetic ketoacidosis, you have to give normal saline. Only problem with normal saline is massive normal saline infusion can produce type of acidosis, that is hyperchloremic acidosis. Clinically it is not a big problem, so you can continue that. So normal saline will be a better choice. If the sodium is very high, then you can go for half normal saline or dextrose solution. In hypotension, if the volume depletion leads to hypotension and early shock, then you have to put 2 IV lines. That is very important. 2 large gauge IV lines are important. Then you have to give fluids in a rate of 30 ml per kg body weight as a bolus. In 1 hour, you have to give 30 ml per kg body weight IV fluid as a bolus. After the bolus, you can see the patient response. How is the patient improving in BP? Whether the patient urine output is improving, whether the patient is developing any complication like pulmonary edema. All these things can be looked into, and you can continue the fluid administration. Crystalloids are ringer lactate is equally effective like normal saline. It has got no contraindication. Only contraindication is severe liver failure. Ringer lactate should not be used. Even in lactic acidosis, ringer lactate can be given. Plasmalite is another solution that also can be given in almost all type of hypovolemia. It's the most physiological solution. Plasmalite is the most physiological solution. Second one is ringer lactate. Third one only normal saline. But comparing with all these three, normal saline is less costly, ringer lactate more costly, and plasmalite is costlier than ringer lactate. Now, when we are giving 1 liter of normal saline, ringer lactate or plasmalite or dextrose, we have to see how much amount is remaining in the intravascular compartment. If we are giving 1 liter of normal saline, around 300 ml of fluid will remain in the intravascular compartment after some time. So whatever we give, it will not remain in the intravascular compartment. It will shift to the extravascular compartment also, but it will not go to the intracellular compartment. That is an advantage when we are giving crystalloids. So if we are giving 1 liter normal saline in a patient who is having diarrhea, around 300 ml will remain in the intravascular compartment for a long time. But initially, all the 1000 ml will remain in the intravascular compartment. BP will improve, circulation will improve. Then it will shift to the extravascular compartment. But if you are giving colloids like albumin, only albumin should be used as a colloid in emergency room. other colloids which was used previously are not indicated nowadays because it has got adverse effects. So albumin 100 ml if you are giving, 100 ml will remain in the intravascular compartment, another 30 ml may draw from the extravascular compartment to the intravascular compartment. But it is not feasible to give albumin in emergency room because of the cost of the product. It costs around 3000 to 5000 rupees for 100 ml, whereas normal saline costs only 90 rupees to 100 rupees for 500 ml. So that is a major difference. But after correcting the intravascular volume with normal saline, ringer lactate, plasmolite, then if you want you can give albumin. Otherwise, in a routine case, albumin is not indicated in emergency room. Now, this chart will tell you that how much will remain in the intravascular compartment after giving each type of fluid. So here we can see the normal saline around 300 ml will remain in the intravascular compartment, 5% dextrose around 100 ml will remain in the intravascular compartment, colloids 1000 ml will remain in the intravascular compartment after giving 1000 ml. So that is the difference, but unfortunately we cannot use colloids because it is very costly, albumin is very costly. Normal saline, ringer lactate, plasmolite, these are the fluids should be used in hypovolemia or hypovolemic shock. And most physiological IV fluid in emergency room is actually it is plasmolite, but plasmolite is not available in every emergency room. So ringer lactate will be the most physiological IV fluid. You can use ringer lactate in almost all types of hypovolemic conditions, especially when there is diarrhea. This is one IV fluid should be started in diarrhea patients, because we can see many patients who is having diarrhea unknowingly many start DNS. That is not a good choice in diarrhea. We have to replace the electrolytes, so we have to give ringer lactate. That is the best choice, either normal saline or ringer lactate, not DNS. Once you correct intravascular volume by ringer lactate, normal saline or plasmolite, then you can give DNS or 5% dextrose to improve the calorie requirement of the patient. So to give the calorie requirement of the patient, you have to give dextrose, and to fill the extravascular compartment also you have to give dextrose. You can see here in a patient who is having severe diarrhea for many days, his intravascular volume will be depleted, his extravascular volume also will be depleted. So initially you have to correct the intravascular volume by crystalloids like normal saline, ringer lactate, plasmolite. Then you have to start DNS or 5% dextrose even to fill the extravascular compartment. Albumin, we have already discussed. Albumin is very costly. It is available as 20% 100 ml. It improves the intravascular volume by 100%, and it also draws some amount of fluid from the extravascular compartment. So it will increase intravascular volume by 130%. That is the important feature of albumin. So if needed, we have to give that. Otherwise, unnecessarily albumin should not be given in patient who is having hypovolemia. Another important problem is hemorrhagic shock. I am not going to discuss about hemorrhagic shock here, but you can see here the chart. There are 4 major classes of hemorrhagic shock. Depending on the clinical feature, we can classify into 4 major groups. In that, why we are classifying this is because from this itself we can understand that whether the patient require blood transfusion or not. And the class 4 require massive transfusion protocol. Massive transfusion protocol means this patient require large amount of blood. So when we are treating a patient with trauma with severe blood loss, initially we will be treating the patient with normal saline or ringer lactate, and patient volume will be diluted. The blood will be diluted there. Loss of RBC with more fluid, there will be dilution. So that will lead to dilution of the coagulation factors and dilution coagulopathy it can produce. To prevent that, when we are giving massive blood transfusion, you have to give 1:1:1 ratio of RBC, platelets and plasma. That is massive transfusion protocol. We will discuss massive transfusion protocol afterwards. So when there is requirement of massive transfusion, you need to give 1 pint of RBC, 1 pint of platelets and 1 pint of FFP. That is massive transfusion protocol transfusion. So when there is a severe shock due to bleed, we have to give blood transfusion in patients who is having hemorrhagic shock. It can be due to trauma, it can be due to GI bleed, or during surgeries. All these things patient can develop hemorrhagic shock. So blood transfusion should be ideally given when there is hemoglobin less than 7 gram per deciliter. But in a patient who is having coronary artery disease, stroke and all, we will have to dilute this protocol. We have to give blood transfusion early itself. Suppose somebody is having coronary artery disease, we will not wait the patient to develop severe anemia, because anemia itself can produce severe angina or cardiac failure, all these things. So in a patient who is having cardiac disease, severe anemia is not an acceptable problem in emergency room. So in that type of patients we may transfuse faster than this level. Now once you transfuse the patient, whether it is ringer lactate, normal saline, plasma light, albumin, blood, whatever it is, we should know whether the patient is improving or not. For that, some parameters we have to check, that is clinical findings for good perfusion. Mean arterial pressure is one important factor, that is more than 65. Urine output is very, very important. If the kidneys are normal, urine output should be more than 0.5 ml per kg per hour. That is the most easily observable clinical parameter. So urine output is very important. Lactate clearance, initial lactate and lactate after 2 hours you can take, and lactate clearance can be calculated. If there is improvement more than 10%, that is also good improvement. Normalization of pH in ABG value, improvement of GCS, and other variants like CVP, central venous oxyhemoglobin saturation. All these things also can be checked in these patients. So we have discussed about the use of various IV fluids in hypovolemia and hypovolemic shock. Hypovolemia can be due to various conditions including vomiting, diarrhea, decay, diabetic ketoacidosis, sepsis, dengue shock syndrome. The causes are different and the mechanism of shock also different, but the treatment initially in emergency room will be IV fluids. IV fluid means it is normally we give normal saline or sometimes ringer lactate or plasma. All are equally beneficial. Some advantage for plasma and ringer lactate is they are more physiological fluid than comparing with normal saline. Otherwise, there is no major clinical outcome difference in normal saline, ringer lactate or plasma. In septic shock and all, plasma has got a better advantage than other fluids, but the cost is 3 times higher than the normal saline. Thank you.